We'll go ahead and get started. On behalf of the Academy of Emergency Ultrasound, thank you everyone for joining us. This is sort of a round two webinar on POCUS reimbursement and some of those topics, and we've selected a few subtopics within there. And the way we'll sort of do this is we have some panelists up here, which I will introduce, and then we're going to move from sort of subtopic to subtopic. And as we sort of move through a topic, I'm going to be watching the chat. And please, this is a great time for questions, interactivity, getting your thoughts out there, clearing confusion, etc. So please feel free to use the chat to put in questions, and I will be attempting to manage that and then bringing your questions up to the panelists as we move through each subsection. You're also welcome to raise your hand, and I'll look for that, but I think the chat is probably the way to get questions out there as we move through. So with that, doing some introductions. So first, we'll start with Stanley Wu. So Stanley Wu did his ultrasound fellowship at St. Luke's Roosevelt Hospital Center. He's an assistant professor at Baylor College of Emergency Medicine and is a prior ED medical director and a prior chair of the ACEP Coding and Reimbursement Subcommittee. So we appreciate having Stan Wu on the webinar. Next, we go to Jason Adler, who is the Senior Vice President of Coding at Logix Health and the current ICD-10 Workgroup Chair for ACEP's Coding and Nomenclature Advisory Committee, as well as an immediate past chair of EDPMA's Quality Coding Documentation Committee. He's also a clinical associate professor of EM at the University of Maryland program, and he serves as the department's Director of Compliance and Reimbursement. The next panelist we have today is Joshua Gutman, who's an associate professor of emergency medicine at Emory University, a former ultrasound fellowship director, chair of the AAEM Emergency Ultrasound Section, and the outgoing chair of the ACEP Coding and Reimbursement Subcommittee. Then we have myself. I will serve as your host. My name is Chris Thom. I'm an associate professor of emergency medicine at UVA and the director of emergency ultrasound here, as well as the physician director of finance and administration for my department. And then last panelist is Rachel Liu. Dr. Liu is a professor of emergency medicine at Yale School of Medicine and is the current director of point-of-care ultrasound education and curriculum director for the advanced training period. She has served as the chair of the ACEP EUS section and the past president of AUS. So those are going to be our panelist group, and welcome to them and appreciate their expertise and their time today. So with that, folks, I'm going to hand over the floor here to Jason Adler, who's going to talk to us a little bit about trends in payer behavior and ultrasound specifically. So Jason, I'll go ahead and hand over to you.
Thank you very much, Chris, and greetings, everyone. We wanted to start off with a macroscopic view of what is going on within emergency medicine and then drill a little bit deeper into ultrasound-specific data. Over the past several years, we've seen a dramatic shift in the payment behavior sphere. I think everyone here is quite familiar with the lay press and other areas, and certainly throughout managing your own department and work that you're performing within the ultrasound area, there's a change of what we'll call delayed or potentially denied payments. And this is a national phenomenon. It's affecting everybody from coast to coast, from Washington down to Florida, Maine to San Diego. And what we're seeing is a transition from immediate, efficient, balanced payment systems where you would submit a claim, it would be pushed through to the payer, and immediately afterwards, there'd be a frictionless process. And that evolution has changed over to an environment where that payment submission is not really the case anymore. There are requests for additional records, there are questions being asked. It's a asymmetric process whereby you have a claim being submitted and then you have a payer immediately pushing it back to the administrative offices, creating a little bit of an unnecessary administrative burden. We're going to talk about how to overcome those burdens that exist. So there has been an increase in prepayment refusals, and these events often don't have a legitimate basis. And certainly as we're in an environment now in 2025 with a lot of downward economic pressures, we want to make sure that we're capturing all the excellent high quality work that we are performing on a day-to-day basis. And ultrasound is no longer an emerging field. It's an established field that requires a high degree of specialty skill that everyone here is very qualified in not only performing, but supporting the next generation of clinicians who are performing that same exact work. And the expectation is that all of those services are expected to be paid for. Appropriate fair reimbursement. Imagine a payer unilaterally just saying, we're not going to pay for intubations anymore. We're not going to pay for central lines anymore. These are common procedures that are part of routine practice in emergency medicine, and that work performed should be credited appropriately in the most frictionless possible manner. So some of the examples of these non-payment processes might be requests for additional records. And these aren't denied claims. It's that language is oftentimes not used in that way because there are contractual issues there. It's just a delay in payment. It's like, please send us this, or please clarify that, creating a long tailwind of potential non-payment that sits on your side and doesn't necessarily get resolved. It's a high administrative burden for the clinical group. And especially within a multi-specialty practice plan, you can imagine where you've got several different departments, there's lots of activity going on. These episodes of appropriate care provided can sort of slip by some, but we're going to talk about how to really zero in and capture that work that you're doing. The foundation of asking for additional records or these other areas are based on an algorithm. It's immediate. You push it through, it comes right back over. Oh, this or that. And the correspondences are highly vague. In fact, if you go to the next slide, Chris, you'll find that here are some recent examples. Actually, first, we're going to go over that this is such an evolving landscape, but unfortunately, it's become really standard now because you can't go a month without finding examples of policy disagreements or new policies being rolled out by the commercial payers modifying their policy manual to have a heightened scrutiny for these high complexity services. Here's an example from Cigna that was released about 1 month ago. Doesn't affect emergency medicine, doesn't affect ultrasound. It's really for the outpatient office side. But what they are saying is they're going to highly scrutinize the high complexity codes, the 99201 or 99205s, 04s. That's the high complexity new outpatient office visits and established patient office visits. The point here is just that it's every month that goes by, every 6 weeks, every 8 weeks, every 2 months, you'll see new policies popping out addressing exactly what we're talking about. But zeroing in on emergency medicine specifically, and what the industry is seeing are these vague EOB correspondences. Here you have N163, medical record does not support code build for the code definition. C0150, payer deems the information submitted does not support this level of service. And the common pattern there is just this generic statement requesting information, unclear what the exact ask is, which delays the payment process of appropriately capturing the work that you're doing. We've talked about this in the past, and just to refresh the conversation, about 2 years ago, United Healthcare specifically offered up a new policy focusing on ultrasound specifically. And the policy within their manual is focused on what the interpretation report looks like, where it should be placed within the body of the medical record, and should it not be in the place that it's believed to be appropriately placed at, then they were reserving the right to refuse payment. That was effective as of October 1, 2024, and that was a heightened sense of focus for some time. Though good news, I'm not sure if there's surveying the landscape using all of our resources that are available through our organized medicine, not seeing a lot of this exact policy being implemented, but these are some of the approaches that the payers are using, United Healthcare being an example of ways to potentially delay payment or modify payment through their policy manual. ACEP has done a nice job of putting together a sample appeal letter here. The QR code is available for you to review. Just one way you could approach some of these denials when they're known to you, and to collaborate with your professional billing office or central billing office, your coding partner, to make sure that you have an opportunity to reach out with the payer directly and advocate for the specialty and on behalf of your practice. Through crowdsourcing, we were able to identify some specific EOBs that are unique to ultrasound. On this example here, this is a First Blue Cross product, and it's a little bit small on the screen, but the remark code on letter E at the bottom is payment denied when performed by this type of provider. Remark code F, the provider type of provider specialty may not bill services. On the next slide, there's an example from Aetna that says the member doesn't owe this amount. The service is only covered when billed by the radiologist. In collaborating with organized medicine and other areas, we've seen remark codes like this. And the root cause there is oftentimes there's a multi-specialty practice that in their contract negotiation process has internally decided that we will need radiology approval for emergency medicine to bill for ultrasound or something in that way. It all goes back to the contracting process of what determines who gets paid in for what way. In these particular cases, both claims were paid to emergency medicine, but there is stuff. And one of the key themes that we're speaking to is it's not always a coding dispute. What we're often talking about is a contractual dispute of payment, going back to the same notion of we're not going to unilaterally not pay for an intubation or that central line. With respect to the transit utilization, on the right-hand side, you have a table here of the commonly performed ultrasound procedures. Looking back at some macro data, we're finding that common studies remain common, chest being among the most common, cardiac, abdominal, retroperitoneal, OB. And then there are emerging utilization trends, something that everyone on this line is completely familiar with, diagnostic and procedure. We're seeing a lot of ophthalmic studies and nerve block studies. Things have changed over the past few years as medicine evolves and ultrasound utilization becomes more frequent. We're seeing that about 3 to 5% of all visits may have an ultrasound visit of an ultrasound procedure involved with the E&M. So over time, we're seeing more and more ultrasound, likely a reflection, and we're speaking in behalf of organized medicine, not any particular area, but the utilization is increasing for sure, and it's increasing year over year. And there are likely several reasons for that. It's because we are educating our colleagues and our residents, and everyone else is using the studies more and more frequently. And there's certainly similar to the reason we're all sharing time together today, hypersensitivity towards capturing that work from the coding and reimbursement space to make sure that work is appropriately captured so that your department could be reimbursed for the work that you're doing. That process has led to increased claims involving ultrasound codes. So we are seeing more automated process that interfere with prompt payment that involves the entire house of medicine. It certainly involves the EMTALA specialties, specifically emergency medicine. And within that, there are some trends focusing on ultrasound specifically, but we don't want to lose the forest of the trees. We know that ultrasound is a highly valuable service, requires specialized expertise, and should always be appropriately reimbursed. Chris, if you go to the next slide, I'll just open up for some free thoughts and questions. I think the biggest, most important area here is understanding that the partnership with your coding vendor, your RCM vendor, your professional billing office is key, because every month that goes by, it's critically important to understand your own data. That could be a line item on exactly what was submitted, exactly what was coded, and critically important is exactly what was paid. And for those line items that were not paid, we need to ask the question, why? Was it a bundling issue? Was it a policy issue? And you can have these conversations with your colleagues, and fostering that relationship and harmonizing within that partnership is not only key, but germane to future success. You may find that over time, things are being submitted and we don't always, some areas might not recognize that there's an ultrasound specific piece to that, but digging a little bit deeper, that partnership is so important because we know we have the expectation that every study performed, documented, and coded will be paid for. And we expect to see more of that in the future. I'll pause for a minute, open up to questions. Contact information is here, and certainly happy to answer anything that you may have.
Great. Thank you, Jason. Please feel free to throw your questions in the chat and I will read those out and we'll go from there. So we do have a question. When you say automated processes for denial, are insurers employing any AI for this use? Are there specific words, phrases, or things we should avoid or possibly include to make payment more smooth or successful?
Yeah, such a great question. Thank you for that. So the answer is, short answer is yes. There are many of these things that bounce back that have no human involvement. Some of that is speculating, but we do know that to be true. And in fact, in response to that, there's a law in Colorado that was recently pushed out and is being sorted through at the moment that focuses on this very issue, includes this very issue. The payers are not looking at the words on the chart, unfortunately. In many cases, they'll be looking at the diagnosis line. So when you get the levels not supported, there's a example that is often used where you see a patient that comes in with right lower quadrant abdominal pain. You perform a medically appropriate history and exam that might involve some blood work, diagnostics, therapeutics. You might get a CT. They have a negative for appendicitis study, but it's an ovarian cyst as an example, and maybe a medically complex evaluation management code at level 5. An ovarian cyst doesn't match up to a diagnosis list that payer may be utilizing to quote unquote screen whether an appropriate code is available. And that process is completely automated. That process does use diagnosis codes. And there's a lot of problems with that. The original list comes from what's called the Lane diagnosis, low acuity non-emergent. And that's widely circulated throughout the insurance industry. Professional organizations, ASAP, EDPMA, SAEM are all involved with, and AEM are all involved with advocacy to combat this behavior. But bringing it home to more tactical framework, we want to be hyper-focused, everyone on this line, of just working with your billing company to make sure that everything is being paid on a month-to-month basis, not in a passive way, but in a very proactive way.
All right, folks, other questions, thoughts from the group, the audience? I will say, Jason, just me being curious here, we see a lot of these behaviors, and often it seems like private payers that try to do a lot of this downcoding or delaying the payment basically through different formats. What have you seen on the public payer side, on the CMS, Medicare, and maybe the state level Medicaid side? Do these issues come up as well, or is it a little bit simpler to get reimbursed for the work you do?
Yeah, it's not uncommon to have your work questioned in one way or another. And that's just the world that we're living in. But with respect to the diagnosis list, the automatic downcoding, or the request for additional records, that's more a commercial phenomenon than it is a governmental phenomenon. Typically, the government agencies will review retrospectively in the form of an audit, routine or otherwise, but you don't often see this type of behavior that we're talking about with diagnosis lists or automatic downcodes with governmental payers.
Very good. Daniel Theodora has a question. Can you expand on options when the contractual obligation is the barrier?
Yeah, that's a really great question because you hit on a really key point of the first section of this webinar. And that's while you may see these EOBs, you might hear the word bundling, you might say, we can't bill for this. It's a policy change. This isn't really, in all cases, a coding phenomenon. It's actually a contractual phenomenon. It's why I opened up with the notion of, oh, United Healthcare is all automatically going to just not pay for a CPR procedure code, intubation procedure code. That would fundamentally change the underlying nature of the contract itself and the payment rules. So focusing on that front end, and I fully appreciate how complicated this is, especially in the academic arena where there's multi-specialty practice plans and managed care contracts that involve a lot of different people and moving parts. Whether you are committing to future policy changes within the manual or whether you understand that contract is so important. If there's language related to, there's favorable language and there's unfavorable language with this. So there's some cases where the contract itself may not be amendable and you might be stuck with some of these changes. There are other areas where if it's proactive and meaningful, the behavior that's being performed by these payers is against the grain of the contract. And that's when you'd have legal representation and people review that to make sure that the claim that we're just not, this is a new non-covered service, that may not be legitimate. And they don't always receive pushback. So that would be the next step.
Very good. Other thoughts, questions, folks? I will say what was helpful for me in just one or two quick slides on the denial piece is I think as ultrasound directors, we spend a lot of time on is it getting coded? Is the procedure note correct? Can the coders see it? And then the denial and some of the payer contracting is certainly a second step that we don't always pay as much attention to. What you see here is completely fictitious. Nothing here is real with regard to charges, payments, etc. It's sort of made up, minus, I suppose, the CPT codes. But getting something like this is probably a good first step to how do we understand when this is occurring? Because as you can see here, you've got enough detail here to sort of pick out that something's going on with Aetna in this case, or something's going on with this example commercial payer. Again, completely made up, fictitious, but just using this as an example where you could then say what is going on with 76705 and this particular commercial payer. And to Jason's point, this is where you go to your rev cycle team and you work with them on, hey, why weren't these reimbursed? Was there an issue? And what you may find is that the folks handling the denials are not the same people largely doing the actual coding. So you've got coders and then you've got other folks in the rev cycle pipeline handling the back and forth with the insurers. And you may find that those folks handling the denials aren't as in the loop on what you're hoping to accomplish with the current coding paradigm. So an easy example is you're getting pushback, let's say from United, they've got this new policy. Let's say they start denying some of your ultrasounds and they're giving you the reason that it should be bundled into the E&M service. Now on the coding side, you worked with your coders, you know that's not supposed to be the case. They're not supposed to bundle it in the E&M service unless it's absolutely necessary. So these are all already being vetted by the coders. And yet United is just assuming, and again, just as an example, commercial payer, one of these commercial payers is assuming that you are bundling them all and just denying it. And you may well have somebody on that rev cycle team that isn't linked in with a professional coding operation and doesn't know that. So to Jason's point, you got to know where these are, where you're getting denials and where you're not getting paid for the work you're doing. And something like this is a great example of how you could sort that. And again, pausing for questions.
It is totally reasonable for everyone here today and for the ultrasound community to fully expect good data from their coding and billing partner. 100%. You want to know exactly what's coded, exactly what's billed, and how much that breaks out to. It's a valid question and can really open to capturing the work that we're doing.
I completely agree. A few of these questions, Jason showed an EOB with maybe a specific type of physician, have also been privy to a commercial payer that uses a specific accreditation pathway. So your department or your physician group, the department has to be accredited by a certain organization, often ACR, AIUM. for ultrasound reimbursement to occur. So things like that you can't identify without knowing that there are denials and then understanding where they're coming from. And Jason alluded to this is not ultrasound specific, but I think these examples are great and you can find these. And basically, if there's a way to downcode, then they will probably find a way to do it. And if there's a way to not reimburse an ultrasound CPT code, they may find a way to do that too. So again, you have to be aware when this is occurring and understand these caveats. And then we showed that. The other thing I just wanted to bring to the attention of everyone is the proposed rule for physician payment from CMS for 2026. I'm sure a lot of folks have seen this, and there is some good in this for sure, in that the conversion factor finally goes up. There's a little bit of bad here for ultrasound specifically, just to highlight in the form of this efficiency adjustment, if you have or have not heard of that. So basically, CMS is sort of making the argument that things have gotten more efficient over time with all of our non-time-based codes or non-E&M codes. So this doesn't affect our 99281 to 99285, but for all our procedure codes, including all of our ultrasound CPT codes, the proposal, not enacted, but the 2026 proposal is to do a 2.5% dock basically in those work RVUs, thus shifting our pot, if you will, of work RVUs a little bit more towards running around seeing patients and a little bit less towards getting reimbursed for stopping and doing procedures and doing ultrasounds. So it's 2.5%, so it's not a showstopper, but it is important. And if this paradigm actually makes it through, it may lead to more cuts in procedural-based specialties. But for us, it may shift the emphasis, I suppose you could say, and where we can earn work RVUs over to seeing patients and away from procedural practice, which of course is not a great thing, but just highlighting it here as something for people to be aware of. Pausing for questions, folks. So question on, and I'll open this up to the crowd. Any advice on figuring out if bundling into MDM versus billing independently is more advantageous? And I think Herbert is sort of thinking how to maximize RVUs and potential revenue for work being performed.
I'd say this was a topic of an entire webinar a couple of years ago, or a large chunk of the ACEP webinar on a similar topic. But at the end of the day, most of the time, the vast majority of the time, it's going to be better for billing if it's done as a separate procedure as opposed to bundling. This is because a lot of our ultrasounds happen on patients that are already going to be a level 5. You think about our trauma patients who are getting a fast exam. They're also getting IV opioids. They're also getting a trauma consult. They're already going to be at the level 5, if not beyond. So bundling ultrasound into an E&M is not going to make sense. And that's going to be the same for our critically ill patients that are getting echoes, or CHF patients who are getting long ultrasounds, et cetera, et cetera. There are some instances where it would make sense to bundle it into an E&M. For example, if there's a soft tissue ultrasound for an abscess, when there's no other imaging, no other labs are going to be done, and that can take you from a level 3 to a level 4, it would make sense to do that. Another scenario might be if you're just doing a renal ultrasound and someone with a renal colic and they're getting labs, but they're not getting any other imaging, that might take it up to a level 4. So a lot of it depends. It's generally easiest to do it where you just do it as a separate procedure just for ease of use. But if your group and coders are savvy enough to get into these specific scenarios, and certainly you can maximize it that way. But in general, separating it as a separate procedure will work the vast majority of the time. And it can also more easily justify your ultrasound use to your C-suite and to your department, where you're saying, okay, here's the money that we're making from doing ultrasound. It's when you're bundling into the E&M, it's harder to tease out. So there's less specific dollars you can bring to them and saying, this is what we're making or what we can potentially make.
I think it does depend on your patient population as well. So if you're talking very large, like urban centers, et cetera, a lot of academic centers and the populations they get, then what Josh says makes sense. There are certain places where it would make more sense to bundle. But for those of us talking about this stuff, a lot of the thought is, even if some cents on the dollar could be made more into bundling, there are many other reasons why we would want to keep it procedural. A, it's kind of, we're used to thinking about it that way, but B, this is what lets you generate your technical fees so that you can continue kind of recycling those fees into program upkeep, which is then really important for robust programs in education and training. But if you are at a site that may not really care about that too much, then you could look at going the other way.
And then another good question from the chat here. I'll read it. Specifically, ultrasound-guided peripheral IV is becoming nearly ubiquitous in practice and steadily bills less and less. would it make more sense to bundle these into MDM, or do they not help that much in increasing the level of, I'm just going to add E&M billing? And that's an interesting one because the ultrasound guided peripheral IV is often two codes. One is the actual IV placed by physician, which is not a ultrasound code, and the other one is an add-on code, I think 76937, which is a procedural needle guided code. So I don't actually know if you can use that as a independent interpretation because it's more ultrasound needle assist for a non-ultrasound code, which is the IV. But curious if the panel has knowledge or thoughts there on that one.
You are correct.
Okay. So can't really be using that independent interpretation, Jason?
That's a procedure. It's not a study that would involve an interpretation. And just pulling the lens back, just refreshing the conversation because we're doing a little bit of a deeper dive. Under the data section of the MDM grid, there's 3 different categories. One is category 1 involves ordering and reviewing labs, external records, independent historian. Category 2 involves your independent interpretation of studies. And category 3 involves your management discussions with consultants. And in many cases, that category 2 will be level defining for the low acuity visits, and in many cases, the high acuity visits as well. We're using the term bundling, but that's on the dovetails of just talking about payer behavior and bundling policies. That's sort of separate and distinct. Just to frame this a little bit in the same way, payers are bundling things, which means not they're incorporating it into the E&M, but not necessarily giving you higher E&M. What we're talking about right now is scoring in the architecture of the coding grid to take an ultrasound diagnostic image and use that independent interpretation under category 2 and thereby defining the level. Just reframing that slightly differently. But yeah, the ultrasound IV would not typically satisfy the category 2.
And then
at my place, we don't even actually really bill out the ultrasound guided peripheral IVs. Was a lot of work for not much benefit, but also it's really hard to keep track of, if the nurses or someone else are doing their ultrasound guided IVs versus when an MD is doing it, and all those kind of things, and just trying to save an ultrasound guided IV if you're a sole provider is really challenging to get, the documentation of what you need to document in order to prove success, that kind of stuff. So we just sort of abandoned plan because there's a lot more things, other things that we do that can capture effectively what we do.
And then David Purdue asks, will many coders do that patient by patient or as a blanket process, all separate code versus bundling? And I think, David, the ideal scenario is you've got a coding group that can handle a little bit of complexity and can code it separately when it doesn't bump the E&M level, and then can include it when it does, similar to what they would do with EKGs. And I think, most coding groups, if you sit down and sort of go through it, I think it's doable because keep in mind, they're having to score the AMA MDM grid either way. So they have to do all that scoring anyway. So having that little bit of complexity of, hey, put it in the E&M if it's the only thing there that will raise the level versus otherwise code it separately. I think if you sit down, hopefully you have success with your coding group and making that sort of fine tuning. Okay, so what we're going to do now is just transition, and I'm going to actually give the floor over to Josh Gutman and Stan Wu, and we're going to talk a little bit about building a system-wide POCUS program and making sort of an ROI and planning on the revenue side of that. So Josh and Stan, handing it over.
Thanks, Chris. Thanks. So just a few essential pieces when you're wanting to build a system-wide POCUS plan, you need a few things in place. Now, most of us, if you're on this call, you probably already are involved in a program that has ultrasound in use and is widely available in your department and or the hospital that you're working in, and an archiving system, a way to save those images. Now, as Jason mentioned, payers are looking for any reason to deny you, and one of those ways could be looking for an image. Now, as far as I know, no one's ever asked for the image associated with your bill for your procedure, or your ultrasound procedure. However, it is one of the requirements for billing for ultrasound is that you have the images readily available should they want to audit or should they want to ask for proof that you have those images. They will want to see, the question they would ask you is, do you have the representative image for the study? And, I'll probably throw it back over to Jason if he's heard of anything, or the rest of the group, if they've ever heard of that, but I have not. So an archiving system is essential if you want to have a system-wide POCUS program. Now, obviously, it would be easier. Most of us are in one department, and if you have something already in place in one department, it's easy to then sort of stepwise add on additional departments and or join with other departments to help your business plan and your strategy for persuading administration to make you have this kind of program. So, we're all, well, I'm assuming most of us are emergency medicine. And so we're all focused on, the main thing, which is where's the money? Give me the money. What's my bottom line? But this is actually a really important piece that you should spend a significant amount of time with, because in order for you to be successful and be able to convince administrators and leadership that this is in fact something useful, you have to communicate all of the benefits. And the only way to do that is to go through this process of finding out, doing all of these things. What is your purpose, your mission, a SWOT analysis, or strengths, weaknesses, opportunities, threats. What's your timeline? And I'll get to that in on the next slide. But you need to, if you don't have an archiving system yet, you need to be able to build out at least 6 months or a year just in making sure that archiving system is usable and easily accessible to your department as well as the other departments. And so it's important to go through each of these parts of your business plan. Now, of course, we as emergency medicine, like I said, we all want to focus on the finance part of it. And, where am I going to get some money for my section and my department? And how can I get buy down, et cetera? And so we tend to skip all of the other things, but it's important that you fill out all of these things in the business plan. It's also important that you realize that your leadership isn't always all going to be emergency medicine docs. So you need to make sure that your plan communicates in a way that, is able to be understood by nursing, by administration, by other people that are going to make the ultimate decision in building this system-wide focus. So I just put a few notes here. So you'll want to come up with, so this is basically boiling down to the finance part of it. And so you'll want to know what's your expected annual revenue. And Josh is going to get into a little bit of that, but you should also come up with 5-year and 10-year projections. Now, I'll just cite a couple of studies. The average income from an ultrasound per procedure, this was based on a 2022 study. Average income from an ultrasound study per procedure was about $410, while the cost from an average procedure was about $55. In 2009, it was a study by Storm and Kuhn and Noble and I think Lateplo and a few others, that an annual revenue of $35,000 revenue, which would include your pro fees and technical fees, assuming that you optimize billing and documentation, could get you about $94,000 annually. And they estimated that your operating costs would be about $68,000. And if you included expenses of machines, that your break even would be about 5 years. So that's just sort of to give you guys kind of a ballpark. This was in 2009. Obviously, things have changed since then. And they estimated your operating income, net income would be about $22,000 a year. And then again, your 5-year break-even point. And so you can use that as kind of a ballpark, but again, that was 2009. I'm sure things have changed a little bit with regards to reimbursement as well as cost of implementation, et cetera. Some of the other things that you should think about in terms of cost is that you should, not just the machines and archiving software if you haven't established those already, but you should probably have at least one director, aide, and an assistant just to start. There's it's really difficult for one person to do it. It's doable, but then you would have to argue for some buy down time. And depending on the scope of your project, depending on the scope of who you're trying to include, obviously that could expand. Now, just as an example, when we started this at my shop, we partnered with multiple services. So we partnered with ENT, surgery, OB. And so the cost was spread out across different departments. And so it was a lot more difficult for administration to refuse us, number one, but also could see that the revenue potential was a lot higher. If you'll see, those are the two articles that I cited, and I will turn it over to Josh.
Okay, so as part of this section, I'm going to address 3 common questions when it comes to the POCUS business plan. How do you estimate revenue potential for an ultrasound program in an institution with little or no prior billing data. Well, when you don't have prior billing data, the best entry point is simply to look at what's already happening in your department. If your scans are being archived and saved or even just tracked for quality assurance, those numbers can serve as the foundation for modeling revenue. Another angle, if you don't have that, is to review procedures that are commonly performed with ultrasound guidance. For example, like femoral nerve blocks, and look how much revenue would be generated if ultrasound was added to the charge and extrapolate from that. If there's no ultrasound tracking at all, trauma volume can be a reasonable proxy. Most trauma patients undergo an EFAST. While not universal, it provides really a defensible estimate. And if you're truly starting from scratch and have nothing at all, you can lean on published benchmarks. For example, Courtney Smalley's review from a couple years back showed that POCUS was used in about 1.3% of community ED visits, and the rates are even higher in academic centers. And multiplying those rates by your own patient volume gives you a conservative, evidence-based starting point for estimating both lost revenue and future potential. And I was actually just before this, I was on a call with a CMO of multiple emergency departments, and he was preparing to make the argument to the C-suite of the health system about the need to expand ultrasound. We actually went with kind of a different angle for all that when they weren't really billing before, is there is a handheld ultrasounds that are already deployed across their system that people had bought individually or physician groups had bought individually. And so that handheld ultrasound company was able to actually pull the number of scans being done by physicians associated with that system, even though they weren't being tracked in any other way. And we're able to use that to estimate how much revenue is potentially being lost if those scans that were done were saved. So you can get pretty creative with this kind of thing in trying to estimate that revenue. So those are a few options for you. The next question is, should a POCUS business plan separate the professional and technical fees, or should they be combined for a more comprehensive justification? When building your business plan, I recommend separating professional and technical fees and tailoring those numbers to the audience you're speaking with. Hospitals and hospital groups are typically focused on the technical side. That means the capital equipment, the archiving systems, the ultrasound director's time, and the QA infrastructure, while physician groups, on the other hand, are more interested in the professional revenue that actually goes in the physician pockets. And that piece can actually strengthen your case when you're negotiating clinical buy-down or education support or even fellowship funding from your department or group. Though this argument can certainly be made of the hospital on the technical side as well. Separating the two streams also demonstrates transparency while still allowing you to present the combined value when you do need comprehensive justification. This could certainly be the case when hospital and physician groups can combine for clinical buy-down time or fellowship funding. And lastly, how does the business of POCUS translate when applied upstairs, given many EDs use fees for service, while inpatients are typically on DRGs? Just to define DRGs for a second, those are diagnosis-related groups, and that's where, on an inpatient side, insurance companies and CMS will pay based on the diagnosis a certain amount of money and not based on each procedure. And so because you can't really tie the ultrasound done neatly to the payment on the inpatient side, the inpatient business case is more nuanced because the DRG-based reimbursement doesn't directly reward the POCUS utilization. Unlike the ED, where fee-for-service billing aligns neatly with ultrasound, on the wards, the financial case is less straightforward. So here, the justification shifts towards the safety, the quality, and efficiency. And so a structured program with quality assurance and middleware, the argument is reducing risk and standardizing performance and strengthening documentation. Clinically, the argument can be made for doing echoes and improving time to get echoes. Often in a hospital, it might take a couple of days to get echoes. So if you can demonstrate that you can save your echo for an outpatient or not need to get an echo at all because it was done inpatient, that's an argument to be made when you're dealing with the inpatient side to fund ultrasound. So you're really doing you're looking at those value drivers as opposed to the direct cost or direct revenue made from ultrasound. I think that's the last slide. Chris, back to you.
Okay, very good. Question, folks, on this discussion. And feel free to jump off mute if you prefer, or put it in the chat. And then Josh, Dan, I'll ask a question while looking for other questions here. When you're doing this financial modeling, what do you settle on for the dollar amount? You just use the CMS conversion factor and estimate it based on RVUs to that? Or do you try to estimate the payer mix and how much might have a higher reimbursement than that conversion factor?
I typically just use CMS because it's neater and cleaner when I'm doing it, because that doesn't translate completely, but it just makes it easier. Certainly if someone's willing to, find what each insurance company is going to pay and break it down, it gets harder. I mean, the argument, even you need to average out how many ultrasounds, because it gets even more nuanced than that. A point of care echo will pay more than a nerve block. Fast exam will pay the most. And so it's easiest just to use CMS, just get an average amount, and then multiply that by the number of ultrasounds that you estimate can be done or has been left on the table from not doing it. So that's the way I lay it out.
Yeah, I would agree 100% with Josh. I think you use a conversion factor, use the CMS's number, and then use that as your base, your bottom number. And then particularly if you are presenting this, it's better to under promise and over deliver, right? Than to promise the world and then fall way short.
Very good. Dan Theodoro has a question. Any thoughts on how we should represent ourselves in systems engaged in ACO contracts?
So I think the first step is if you could have a seat at the table and have emergency medicine represented in these ACO negotiations, that's the first step. Diving a few layers deeper, it's really complicated. And the multi-specialties practice plans, I'm just focusing on the academic medical centers. You want to just have a seat at the table and be available to be part of that decision-making process. It's challenging with other bigger specialties like the Department of Medicine, Department of Surgery, and all the subspecialties that are associated with it. But we want to make sure that in the spirit of making sure that there's a lot of these ACO arrangements focus on coordination of care and finding out patient visits and decreasing utilization and things of that nature. Our goal is to make sure that emergency medicine is well represented.
Fair enough. Thank you, Jason. Other questions, thoughts from the group?
Well, just to piggyback off of what Jason said, in many departments, in most of our departments, we work closely with surgery. And I think, sometimes those relationships are not quite as friendly as they maybe should be, but that it might be a way where, because they're a much older and bigger specialty, it's potentially a way you could partner with them, build a bridge, and then, sort of negotiate together.
Very good. Well, seeing a few minutes left and realizing this is a big topic, but curious from the panel, any thoughts, and then maybe from the group as well. There are some ACGME proposed changes out there to residency requirements, the big one being the 3 to 4 year, but there's also a lot of ultrasound implications there. To the panel and then anybody in the group, does anybody see an impact of those current ACGME proposed changes to our ability to negotiate for academic buy-down, to run an ultrasound division or section, and to sort of succeed in academic ultrasound roles?
I'll just say, with another hat as the AAM chair, I was privy to be on some of those meetings. I can't share too much, but I'll just say that what was put out as far as the proposed changes are unlikely to be the final changes for ultrasound, and it will hopefully be more favorable for us. But it would get difficult if it wasn't considered a key index procedure to argue that it should be done. And then it really comes down to making that maybe some financial argument about why it should continue to happen, although it's certainly more difficult.
I don't know. I'm from a 4-year program, so it wouldn't really affect me that much. But I think that's really hard to answer, kind of, because I think there could be some argument for supporting faculty more, because of the higher requirements going from 3 to 4. But we all know in our environments how much more could be supported that is not. And this is very much tied into the financial situation of your department or health system as to kind of like how hiring goes, particularly if you are at places that, might potentially be affected by what's going on with NIH research dollars right now, et cetera. So I don't know that the argument that you need more faculty would necessarily result in faculty being hired, if you know what I mean. So while helpful, I don't know that it's a direct relationship.
Yeah, fair enough. Very good. Yeah, I think other thoughts, questions from the crowd?
I think going back more to like business plan as to what Stan and Josh were doing, This is also a little difficult, but we are seeing more people get joint appointments. So for instance, EM and radiology, EM and anesthesiology, and that can be helpful, obviously for the partnership standpoint, but for kind of making plans where someone who is taking a system-wide director role will also receive financial support because now there's multiple departments supporting that role. So that's one thing that can happen out of system-wide community stuff.
Yeah, it's interesting because it's sort of, is the health system going to pay completely for it? Is the department going to get involved in the financial support for it? And I guess if you, like you suggest, Rachel, if you spread it, then that gets easier. Matt Rosenti asked a good question. How much support are you seeing for system-wide? Any experienced folks, ballparks? And Rachel answers usually maybe 0.2, 0.3 FTE. And I've seen that all the way down to 0 and all the way up to 0.5. So it really depends. But yeah.
I'm echoing Chris's numbers, trying to argue up to a 1 at some point, but I've still yet to see it.
Yeah, and it probably depends a lot on the Matt, on the scope, who you've involved, what you plan to accomplish, whether you do have a business plan showing financial revenues coming in, et cetera, or whether you're just sort of looking at more of organization, safety, quality, those kind of things. But either way, certainly make the case if you're going after this to get yourself supported for it, because there's nothing worse than, too many roles that are unsupported, that equals unhappy face over time.
I think health systems are starting to get it. I mean, like mine's quite a large health system, and literally POCUS has now been named twice in their top 10 goals for the year in terms of capitalizing on what everyone is doing across the health system. And so they're really looking towards us as we have the most experience, to help drive that. So that's a great leverage point for anyone trying to get into system-wide stuff with some protected time.
Yeah, and to Matt's point, I don't know that there is a public data point. Does anybody on the panel know if there's a national benchmark on this FTE support for a system-wide position? I haven't seen it, but
not publicly published,
Yeah.
but at the University of Maryland, there is now a division of ultrasound that is a system-wide role that's run through the Department of Emergency Medicine. Really great acknowledgement of the hard work and dedication of the folks at the department doing the great work that they're doing. Just a few final thoughts, Josh. I really like what you mentioned about, you brought up good advocacy opportunities for AEM and the 4-year conversion. Great news. I know it's a sensitive topic at a sensitive time, so not going to probe it all, but I think that the key point there is that being a member, supporting the organization, AEM specifically, SAEM specifically, really does move the needle in these specific areas that we're focused on as emergency physicians. It's really great stuff. And then moving on to the business side and developing a pro forma, a business model in the ED or beyond the ED, my closing thoughts would just be focused on understanding your data. Earlier, we spoke about the importance of understanding your billing data all the way down to the line item with the expectation that every ultrasound is captured or accounted for one way or another. In a good, better, best model, that's probably the best. And we'd like to see that happen everywhere. If you can't get that, then the next step would maybe be looking at your coding data. And if that's not good enough, then maybe you're going to look at your pull from the EHR just to see what's documented. And an individual template or certain macro or doc, something that could be scaled up within a department that you could pull it to understand exactly the work being performed in your department would be highly advantageous, because that way you know exactly what's being done. And you could parlay that into contract negotiations or system-wide conversations, because once you have that data, you could use, as mentioned earlier, the CMS, RVU, conversion factor for 1 year. You could do a blended rate, however you want to come up with the math, but at least you know the number of studies that are being performed. And then that work could really be appropriately credited. And then with the contractual piece that I dipped into just a little bit, there's also the opportunity for a case rate, right? We're talking about bundling issues, bad payer behavior issues, but case rates exist. And that's nothing more than identifying what a department is doing. And instead of getting paid based on the level of service or additional CPT codes, it's just a flat rate for every patient that comes through. And that option always exists out there as well. And the way you have that conversation is to also just know your data. So there's lots of opportunities out there for everybody.
I was just saying, yeah, sometimes you got to be a little creative, and then it doesn't mean even if you don't have anything historically, you can't start now and start deciding on a game plan and start collecting things going forward. I mean, in academics, the amount of ultrasound we tend to do at the larger centers that we're a part of, over 6 months time is huge. And even then will translate into a lot of dollars. So even coming up with a plan to try to track it prospectively, even if you're having difficulty retrospectively, will pay dividends, I think. And just to keep in mind that ultrasound is really even though, yes, as John said, reimbursement is going down and, we're having trouble with finances general in medicine these days, but thinking about an academic and educational route, I mean, as grants have been going aside too, this is basically one of the few academic things that we do that is reimbursable. So that's some argument, like the educational stuff that's done, program directorship, things like that are often not reimbursed or can't be directly tied, but ultrasound can be directly tied to some element of reimbursement and payment. So you can really focus on that and know that we're starting from a place of strength coming into some of these negotiations.
All right, very good. Well, with that, we'll sort of stop there. But thank you to the panelists. Thank you to all the attendees, and appreciate everybody's time here today. Hopefully it was a productive conversation. Feel free to email any and all of us with any questions, and we will go from there. Thank you all.